Welcome to the Mastering Your Fertility podcast. This show is all about reclaiming health, enhancing fertility, and preparing for pregnancy. We're Kristen Cornett and Dr. Haley Nye, your hosts and the creators of the online fertility platform, Tiny Feet. At Tiny Feet, we use functional medicine and nutrition to help couples overcome fertility struggles, conceive successfully, and have beautiful, healthy babies. We offer individualized consults that include functional lab testing and targeted natural therapies, as well as an online fertility assessment and online courses. You can learn more about us on our website at tinyfeet.co. We're excited to be here with you today for episode 31 of the podcast, where we're going to be talking about what to expect when you seek out conventional fertility testing and treatment. Although our passion and expertise really is in natural and integrative fertility care, we want you to be aware of your conventional options too. So if you're struggling at all to conceive, it's so important that you really receive a thorough evaluation and that you understand all the different treatments that are available to you. We also know that this process can be really confusing and kind of stressful, and we just want to break it all down for you and give you the facts that you need to be informed as you continue on your journey. So today you're going to learn about the 3 types of conventional tests you should have if you're having trouble getting pregnant and when you should seek those out. We'll talk about the different options you may be recommended for fertility treatment, how each of them work, and the typical success rates. And then we'll also talk about the side effects, the risks, and average costs associated with conventional treatments. So this episode today is brought to you by our Fertility Recovery Guide. This is a totally free resource that we created to help guide you through some diet and lifestyle changes that can really boost your fertility. So whether you're trying naturally or you're going through one of the fertility treatments that we're going to talk about today, the 5 steps that we outline in the guide are proven to support your hormone balance, improve your egg quality, lower inflammation levels, and also help normalize weight and metabolism, and just generally help you feel better. So these are pretty easy changes that you can really just start making today, and we give you really specific advice on how to jump into each one. And you can download your free copy right now through the link in the podcast episode description. All right, so let's jump into the episode, and we're going to start with talking about what a conventional fertility evaluation is and when you should start to think about having one. So I'm going to jump into that, and then Dr. Haley is going to start talking about some more specifics. So with conventional fertility evaluation, this is typically something that a couple would start seeking out if you're over the age of 35 within about 6 months of unsuccessful attempts at conceiving with timed intercourse. And if you're under the age of 35, it would be a year of no baby after 12 months of timed intercourse. And so there's 3 different types of evaluations, and then within that, there are different tests that can be done. So the first thing that we would want to assess for, and that a fertility clinic would typically assess for, would be ovulatory status and ovarian function. So making sure that you are indeed ovulating every month, and whether or not your ovaries, which produce your sex hormones, are functioning normally. So the different tests that you would probably have, it would start with like a day 3 FSH, which is follicle stimulating hormone, and a day 3 estradiol, which is your estrogen. And those 2 can be used to assess your ovarian function as well as your ovarian reserve. So how many eggs you might have available to ovulate. It kind of gives an idea of, I guess, how old your ovaries are. And then in addition to that, we would probably do an AMH test, or anti-Mullerian hormone, which is also a measurement of ovarian reserve. And so depending on how those hormone tests come out will kind of determine whether or not your ovaries are functioning normal. So if your FSH, for instance, is high, that means that your ovaries aren't necessarily responding the way that they're supposed to the brain saying, hey, let's make estrogen. And so that can indicate a problem with ovarian aging, or I guess heading toward menopause, or poor ovarian reserve. And so if you've got a high FSH and a low estradiol, that's kind of like moving toward ovarian failure, basically, or insufficiency. And then there's also an issue if you see FSH normal, but your estrogen is really high. So those would be some red flags that you would be looking for there. So if you're not having a cycle at all, that can indicate a couple of different things. So either your brain just isn't communicating with the ovaries, or there's a problem and you have an irregular cycle and you have this like hypothalamic pituitary dysfunction. And that's like kind of inconsistent communication to the ovaries. So, some other tests that could be done, additional hormones that would be tested would be your progesterone levels, your TSH, which would assess for thyroid function, also your male hormones, if you have any signs or symptoms of androgen dominance, to assess for PCOS, which would also probably come along with an irregular cycle in most cases, or just absent periods altogether. And you can also be doing some tests too. You can kind of look at your ovulation predictor kits to see whether or not you're ovulating monthly, and your doctor can use that information to help substantiate some of these other tests. And then you may also have an ultrasound as part of the testing for ovarian function. Anything else you want to add to that, Dr. Haley?
No, conventionally, I believe that you covered most of that.
Oh, another test one I didn't mention was actually prolactin. So that's another one that can be measured. High levels of prolactin, yeah, can cause problems.
Yeah, that should always be part of the hormone testing panel as well.
Yeah. So after hormones and assessing for ovulatory function would be looking at any anatomical issues that may be present. So something called an HSG, or hysterosalpingogram, and that's typically done day 7 to 12 of the cycle. And basically what that's testing for is tubal patency, or testing whether or not your fallopian tubes are open and allowing an ovulated egg to make it from the ovary all the way into the uterus to actually be fertilized and implant and grow into a baby. So
Yeah.
some women may have a history of like pelvic inflammation, PID, even endometriosis can obscure the tubes, and so there are certain diagnoses that will basically result in needing to do IVF because it's not anatomically possible to conceive naturally.
We
Another, go ahead.
didn't we talked about this last week with Krista's episode,
Mm-hmm.
where she ended up waiting quite a long while, over 5 years, to get the HSG done, and just asking her, like, do you feel like you should have got that done earlier? And she definitely 100% was yes, just because they did find some blocked tubes. And that was very indicative of her, of why she was having trouble conceiving.
Yeah, so definitely this is one that is a good idea to have done earlier if you can. It's just good to have the information of whether or not there's any sort of anatomical issue. Now, that doesn't mean that other, natural therapies or things can't be helpful or supportive of fertility treatment. But if you end up finding out that you need to do it, finding out sooner is better because your success rates are higher when you're younger for fertility treatment.
Yeah.
So, another type of imaging that could be done is a hysteroscopy, which actually evaluates the inside of the uterus for any anatomical abnormalities. So, something that you could be born with, like a uterine septum that might cause problems with implantation or growth of an embryo, or even other things like polyps or fibroids that might be growing. So, you might suspect that that's an issue if you have a family history of that, or, maybe if you've had a Dutch test and you find out that your 16 estrogen pathway is a little bit upregulated, and you might tend towards some of those abnormal growths like polyps or fibroids. So,
Also, recurrent miscarriages too is a good
yeah,
reason to have that hysteroscopy done.
to make sure that there's nothing that's, causing early loss. Yeah, definitely. And then the third type of test, which includes either both a normal semen analysis as well as maybe some other testing for the guys, is you just want to make sure that that half of the genetic contribution that's needed to build a baby is actually healthy. So a traditional semen analysis is a great idea to do kind of earlier on in the journey. And this is likely something that they'll do pretty soon after starting with a fertility clinic. It's not very common that you'd get too far into working with a fertility clinic without doing a semen analysis. So you want to make sure that we investigate the guys as well. So your typical test is going to include as sperm count, motility, and morphology. And those are a pretty good indication of overall sperm health and ability to actually fertilize an egg. But there is also some other testing. You can actually test for like DNA fragmentation. So you can technically have a normal semen analysis with count, motility, and morphology and still have high levels of damage to the DNA within those sperm. And that can increase the risk for miscarriage and other complications. So that might be something that could be considered for some couples. It's not necessarily important for everybody to do. But if you're suspecting that there might be some male factor involved, that would be something you could consider. And I think some fertility clinics do recommend that. It just depends on where you're going.
For sure. Yeah, and we talked a lot about male fertility in episode 19. So if this has sparked your interest, you can listen to episode 19 and get a lot more information on what Kristen was just mentioning.
Yeah, we talk a lot about sperm quality, how to assess it, and then, of course, how to fix it if it's off in that episode.
Mm-hmm.
So
And
that's
then,
gonna go ahead.
oh, I was just going to mention our recent episode 27 with Dr. Jacqueline Chassie. We talk all about egg quality, which you were talking about earlier with FSH and estradiol. So if that's new to you and you haven't listened to that episode, that's another episode to go back and listen to, because we actually give real numbers of what you're looking for when we're assessing for ovarian reserve.
Yeah. So I think what we're going to do now is start talking about treatment. And Dr. Haley is going to start talking about the specifics of medicated cycles. And so we'll talk about those and we'll talk a little bit about IUI.
All right. So the first thing you can expect when you are starting any type of fertility treatments is they actually have three options for you. So the first one is super ovulation. So they're using medications to induce ovulation, which you can use with either IUI, which is the second option that they have, intrauterine insemination, or you can also use it with timed intercourse. So I'm going to talk about that a little bit more. And then, of course, the third option is what most people know as assisted reproductive technology, or IVF, so in vitro fertilization. So we'll go into that as well. So the first one I want to talk about is super ovulation. And so this is reserved for couples that, or women who may have some type of anovulation diagnosis going on. So PCOS is one diagnosis that comes to mind that is often used in this particular case. And advanced age too. So if you have just diminished ovarian reserve, then using medicated or medication to be able to induce ovulation is maybe a good first choice. And so the one medication that a lot of people have heard of is Clomid, or also known as clomiphene citrate. And you would use this particular medication to lower the estrogen. So it blocks estrogen receptors. And so it actually tricks your brain into making more estrogen. And estrogen is what's going to stimulate more follicles from to be produced. And so you take Clomid, it produces more estrogen in kind of that roundabout way. And then it's actually going to first stimulate the production of follicle stimulating hormone, or FSH. And so people who take Clomid, about 80% of women will ovulate. And then taking it over a 4 to 6 month period, about 40% of those women do become pregnant. And that's without the use of IUI. So that's a pretty high rate, and that's a good place to start, definitely. There are some side effects to using Clomid, though. You may feel nauseous, have some vomiting, hot flashes because it's reducing your estrogen. Also, things like ovarian enlargement with pelvic or abdominal pain. So your ovaries actually get enlarged because of the increase in estrogen and ovulation or follicles. And then it also may reduce your endometrial lining and the production of your cervical mucus. So it can kind of dry you up and make the lining not so receptive to the fertilized egg, which seems
Counterintuitive.
Counterintuitive. Exactly. Thank you. So there is actually some natural treatments that you could do to mitigate that. So in research, they've used black cohosh in addition to Clomid, which has shown to reduce those side effects, which is pretty amazing. They also use N-acetylcysteine, which we've mentioned on the podcast before as one of our favorite supplements, and that also can help mitigate the side effects of using Clomid. So you may want to talk to your doctor about those additional supplements to help if you're using that. Another medication that they use is called letrozole, or the brand name is called Femara. And this is actually an off-label medication used for fertility, but it does have fewer side effects than Clomid, and it uses a different roundabout way of reducing estrogen to increase natural stimulation of FSH. So then you end up making more estrogen, but it just uses a different approach. And so it does have less side effects. But you do still get a few side effects. So they're going to be the same that I just listed off with Clomid. They're just not as common. And then it doesn't come with the side effect of the thinning of the endometrial lining, which is really nice. So often the letrozole is used in women with PCOS. It's a pretty common medication. They may also use it in addition to using metformin as well. So that's also been shown to be pretty successful. And then the last resort medications that they might use is gonadotropins. And the gonadotropins is actually not tricking your system into making more estrogen. It's just giving the hormones straight up. So gonadotropins is actually synthetic FSH and LH, and they do it in combination, and then it's a sub-Q injection. So you're actually injecting yourself with these hormones. It could be kind of dangerous just because, again, you're giving exogenous hormones and inducing more follicles with those. And the reason why it's dangerous is it can cause ovarian hyperstimulation syndrome. And we'll talk about that in a little bit as well. So like I said, these three medications can be used on their own with timed intercourse, or you can also, and often it is, used with an IUI. So I'm going to talk about IUI real quick. So intrauterine insemination is the next step if you're using assisted reproductive technology. And if you're under the age of 35, that's usually where they'll start you on is IUI. But if you're over the age of 35, then it's actually becoming more and more common to just go straight to IVF, especially if you have some type of diagnoses that indicate that IVF would be much more successful. One of the reasons for that is IUI is only 10%, has only a 10% success rate. So you do need to do it multiple times in order for it to work for you. And the success rate for IVF is a little bit more than that. And I think the reproductive endocrinologists, or we'll also call them REs, like IVF because they just feel like they have a lot more control. And you'll understand why once we go into that. So with IVF, with IUI, or intrauterine insemination, it is really helpful to use when there's a male factor infertility involved. So if you have anti-sperm antibodies, also if there's low sperm count or motility or hostile cervical mucus, which is a woman's issue, but those are often reasons why they would use IUI. Also, same-sex females will use IUI often with donor sperm. And so what they do is they just place the ejaculate directly into the uterus, and it allows the conception to take place naturally. And like I said, there isn't a very big success rate with that. You can also do at-home cervical cap insemination, which has around the same success rate as actually going to a clinic as well.
Actually, I have a
But
good story about that. So
do
we
you?
actually, yeah,
Go
well,
for it.
you might not have seen this yet, but we just got a message on our Instagram from somebody who listened to our podcast episode with Lisa Hendrickson Jack, and she was talking about a cervical cap versus IUI and some like similarity in success rates, and like maybe even a little bit better for certain situations. And so one of our podcast listeners tried that, and she's pregnant.
Wow.
Yeah,
Oh,
really
that's so
exciting.
cool. That's really cool. Yeah, I had a patient come in and I was super excited to tell her about the cervical cap device that I just discovered. And I have a demo at my office. And so I got it out and I was like starting to demo it to her. And she, after like 5 minutes of listening to me, she's like, Dr. Haley, that's really sweet that you showed me this, but I'm actually pregnant. I was like, you just let me go on and on and on about this cervical cap device and you're pregnant. Great.
That's
Um,
funny.
yeah, it was really cute. So, yeah, so that's IUI. Kristen's going to tell us a little bit more about the next big step, which is IVF.
Yeah. So with IUI, you're pretty much ovulating essentially naturally. And really what we're doing is taking the sperm and trying to get it closer to the egg. And so conception still occurs inside the woman's body with IUI. But with IVF, we're taking things a step further. We're trying to gain more control over the cycle, and we're actually conceiving outside of the body. So you're going to go through a protocol that will basically stimulate multiple follicles to grow. And then those eggs in those follicles will be needle aspirated out of the ovaries. So it's a much more invasive procedure. And then those eggs will be joined with sperm, basically in a petri dish, or in some cases, injected directly into the egg. That's in a process called ICSI or ICSI, intracytoplasmic sperm injection is what that stands for. And so that's one way that they can do the conception, or just bringing the sperm and the egg together. And then, however many of those eggs fertilize, they'll then allow those to grow for about 3 to 5 days into what we call a blastocyst. And then you can either do a fresh embryo transfer, so that embryo will be transferred in the same cycle, or those embryos that survive to blastocyst can be frozen and then thawed and transferred at a later date. So, some women will go through multiple stimulation cycles to try to kind of get as many eggs and embryos fertilized and frozen as possible. And then they'll choose dates and cycles to do an FET or a frozen embryo transfer after that. So, like I mentioned, ICSI or ICSI is common with IVF, and actually in the U.S. the number is pretty high. We just looked at some statistics that said 66% of IVF cycles included the sperm injection directly into the egg. So we've heard stats as low as 30% and as high as 66%. So I think it's going to depend a lot on the clinic that you're going to and what your reproductive endocrinologist recommends in your specific case. And that also depends on your diagnosis, whether or not there's a male factor involved, whether they would choose a specific sperm to inject into the egg. And we'll talk about some risks a little bit later on, but there actually are some risks to injecting a sperm directly into the egg that are more related to the health of that child as they grow older. So we'll talk about that a little bit later. So, when we're going through IVF and we're doing these ovarian stimulation protocols, what we're basically trying to do is just stimulate the ovaries to grow more eggs. So, typically in a natural cycle where you're not using any hormones or birth control, you're just trying to conceive naturally, you're going to have multiple follicles that are developing, but one is going to kind of take the lead and grow bigger than all of the others. And just that one follicle will ovulate. And in IVF, we want to grow as many as possible. And then we don't let them ovulate naturally. That's when we do that needle aspiration and remove them from the ovary. So this does involve drugs to basically mimic a natural cycle without allowing a full ovulation to take place. And so we're mimicking this normal physiology. So we'll do an initial high dose of FSH to really recruit those follicles and get them to grow, and then do these step down regimens. So this may or may not include pre IVF suppression of your natural menstrual cycle. And that depends, we don't necessarily want to have, too many follicles growing. It can often be helpful, especially in cases of endometriosis, to suppress your natural cycle so that we're kind of starting fresh essentially with the IVF cycle. And there are three types of medications that are typically involved in IVF stimulation. So you'll have a GnRH agonist or antagonist. So this is the different types of medications that do essentially the same things. But the point is to get FSH high and to suppress LH, because if your LH spikes, then you ovulate, and that's not what we want. Um, so we'll use the GnRH agonist or antagonist, and then we'll use FSH, injectable FSH, like Dr. Haley mentioned earlier with gonadotropins, and that stimulates those multiple follicles to grow and mature. And then when we get follicles to the size that we want them, which is typically, I think it's between 15 and 18 millimeters, then we give an HCG trigger shot, and that pushes the final maturing process of those eggs. And then within 36 hours, like exactly 36 hours after trigger shot, is when they'll go in and remove those eggs from the ovary. And so that's kind of the basic process. Now, as you can probably imagine, these drugs do have risks. There's a lot of monitoring that has to be involved, and so IVF is a very involved process. You're really going to get to know your fertility clinic really well and all of the people who work there. So you'll be doing, blood work to monitor your hormones. You will have testing done. You'll have an antral follicle count done on day 3 of your cycle. And that actually gives us a clue as to your antral follicle count. So, how many little primordial follicles that you have developing in your ovaries before you start your IVF helps determine what your response will be to medication, and also helps determine what your prognosis will be for that IVF cycle. So the fewer antral follicles you have on that day 3 ultrasound, the lower your response is going to typically be to IVF medication. So if you have less than 5 antral follicles on that day 3 test, that's going to indicate a poor response to IVF. So if they do choose to go forward with your cycle, often IVF cycles will be canceled for a low antral follicle count. But if you are allowed to go through with your cycle, you'll likely need a higher dose of stimulation, basically, to go forward. So you'll also have your AMH measured in this process. We talked earlier about AMH, and that is a measurement of ovarian reserve, and that can also help determine response to IVF medication. And then throughout your protocol, throughout your stimulation protocol, you're going to be monitored via ultrasound every 24 to 48 hours. And that's to determine the size of the follicles, because they need to get to that certain size before you can do your trigger shot. You don't want them growing too quickly or too slowly, and so you'll be monitored every few days. And you'll also have your endometrial thickness monitored, and this is especially important if you're going to do a transfer in the same cycle. You want to make sure that your endometrial lining is thickening appropriately. And then you would obviously have progesterone after your trigger shot to make sure that it fully matures and is ready for your transfer. And then, like we mentioned, that HCG trigger will be given when your follicles reach the right size, and then you'll have egg retrieval 36 hours later. So, when you're going through stimulation, we talked about antral follicle count being a somewhat predictive measure of your response to IVF stims, but your response to the medication itself, in terms of how many follicles ultimately mature, will help also determine your prognosis. So, a normal response to IVF stimulation, or a good response to IVF stimulation between both ovaries, will be about 10 to 20 follicles total. So, that indicates that you have relatively normal ovarian function and you have a good prognosis, or a good chance of your IVF cycle resulting in a pregnancy and a baby. If you are a hyper responder, and we'll talk a little bit more about this when we talk about risks, but a hyper responder, so you're very responsive to your IVF medication and you develop a lot of follicles. So if you're going above 20 follicles that respond to IVF stimulation, you're at a high risk for ovarian hyperstimulation syndrome, which we'll discuss the risks and symptoms of what that looks like later. And that's common in women who have polycystic ovarian syndrome and already kind of have a lot of those follicles developing in their ovaries. That's what polycystic ovaries essentially means. And so that can be dangerous. And that can mean that either you're just a really high responder or that maybe your drug protocol was a little too aggressive. And if you have fewer than 4 follicles develop through IVF stimulation, that does suggest that there's some ovarian aging or declining reserve going on. And that does typically have less of a chance of resulting in a pregnancy and a live birth. So now that I've kind of gone over the basics of IVF, Dr. Haley's going to talk us through the specific stages, what's happening at each stage, what drugs we're using and what we're looking for.
Yes. Thanks, Kristen. That's a very elegant way of saying what's going to happen when you embark on IVF. I also forgot to mention with IUI that they also give you a trigger shot, or sometimes they do. But in a lot of cases, they actually recommend to do a trigger shot, which is the HCG that Kristen mentioned. So they'll ensure ovulation before they do the IUI.
And they'll typically do that when they're using gonadotropins in the protocol, as opposed to just using like a Clomid or a Femara.
Mm-hmm. Okay, so phases of IVF. The pre-stimulation phase is where they're going to essentially shut down your cycle. So when we say that they have total control over your cycle, we're not kidding. They want total control. And in last week's episode, when Kristen was like, yeah, I felt like I was just, or Krista was saying I was handing my ovaries over to the clinic. She truly was. Like, there's no joke there. So the pre-stimulation phase is they're shutting down your cycle to limit any of the follicles from growing. And so once they stop that natural cycle, then they can start a new cycle with a new cohort of follicles. And so that lasts usually one full cycle before they start the stimulation medications. And then once you start your menses and you start the first follicular phase of that next cycle, they're going to start the stimulation medications. And so those are the medications that Kristen mentioned, which is the gonadotropins or the GnRH agonist or antagonists. So these are all going to be chosen by your RE in exactly what kind of protocol you're doing. And so there's short protocols, there's long protocols, and those are all going to be determined based off of your response to stimulation. Like Kristen was saying, if you're a normal responder, a hyper responder, or a poor responder. Now, of course, during this whole time, they're going to have to monitor you for the ovarian hyperstimulation syndrome, which is something you absolutely want to avoid. It can be a medical emergency. It causes abdominal discomfort, nausea, vomiting, diarrhea, bloating. It can also result in rapid weight gain or respiratory difficulty, kidney stress, and even death. Okay. So definitely REs are on the lookout for this OHSS and that's one of the reasons why they need to monitor you very closely and why you have to kind of head to the clinic every 2 days or so.
Yeah, and if we think back to, I think it was episode 21 of the podcast, we interviewed Parijat about her book about healthy high-risk pregnancy. And that was actually one of the complications that she had during her IVF. And part of what led to her high-risk pregnancy was OHSS.
Wow. Yeah, that's right. So it's real. It's real and it's scary. So the next thing that they're going to do, so once you go through the stimulation process, which is fairly quick, I mean, it's, you have 2 weeks and then you're supposed to ovulate. And so they're controlling that 2-week period. And like Kristen said, once your follicles get to a certain size, then they're going to give you a trigger shot, that HCG trigger. And then at 36-hour mark, they're going to retrieve those eggs. And so you'll go in and you'll be under general anesthesia, and they will aspirate as many follicles that they can get, or how many eggs. And that's the toughest part, recovering from that egg retrieval for sure. And then after that, they're going to give you progesterone suppositories. And so it can support and sustain the endometrium or the lining of the uterus for implantation while your eggs are in the lab being fertilized and hopefully growing.
And I do think you also need that progesterone support, even if you don't do a transfer that cycle, to kind of counteract some of the hormones in your system. Is that right?
Oh, yeah, definitely. Yeah. Yep.
Yeah, I think all of that, the intensity of those hormones without the right amount of progesterone to counteract them might lead to a pretty miserable luteal phase.
Oh, yeah. You would have to go to a private island and be like, nobody talk to me for another couple weeks until I come off of these hormones. Okay. And so there's some other additional risks to going through IVF. And so we're going to just talk about those now. One major risk, which some people are totally okay with and some people aren't, is multiple gestation. So having more than one baby. Oftentimes, 2 embryos or 3 embryos are implanted in the uterus during the transfer. And the reason why they increase those, especially when you're in advanced maternal age or over the age of 35, is to increase the likelihood of at least one embryo taking place and becoming pregnant. But oftentimes it does lead to multiple gestation or twins or triplets or more. And with using Clomid, so this is the medication that we talked about when you're not using IVF, it's a 7.5% risk. And when you're using IVF, it's a 15 to 20% risk. And so that, I say risk, but basically chance, right? Like, so if you decide you want to have that many embryos implanted, 20% of the time, you're going to end up having, 20% of the cycles end up in twins.
When you have a little bit more control over that, if you do it with IVF, you get to decide how many embryos go in. With Clomid, when you're doing a medicated cycle without a procedure, you don't necessarily have control. You get this like super ovulation and you might ovulate more
Yeah,
than one egg. And so you get to decide with IVF whether or not you want that to
right.
even be on the table versus Clomid, you don't necessarily get to do that.
Right. So you have to know going in, are you okay if you end up
With
having
twins
twins?
or more.
Exactly.
My mother-in-law always jokes with me that when we go through our first pregnancy that I'm gonna end up with twins because we have it in on both sides of the family, like natural twins, and I'm like, "No, no. No, thank
Yeah.
you. One is enough." And that's not to diss anybody that has twins. I'm sure if I had twins, I would obviously love them and be thrilled with the fact that I had 2 babies, but if I have
Uh,
a choice, I'd one at a time, please.
yeah, I totally agree. Now that I have one of my own, man, I agree 100 million times percent. Okay, so some risks. First of all, a couple stats. So with babies born in the US, 1.5% or almost 2% of babies are born from IVF. So that's not an insignificant number. And then I have a paper here on stats for um, IVF cycles that happened in 2016 in the US and your success rates. And so we just wanted to give you a really clear idea on what to expect. And so with women under the age of 35, the success rate is going to be the best. Obviously, you're younger. And now outcomes per cycle, what we usually look at is cycles resulting in live births, right? So there's cycles that end up in implantation, cycles that end up in pregnancies, but obviously the goal is a live birth, a baby at the very end, right? So in women under the age of 35, 31% of cycles or IVF cycles will end up in a live birth. But when you're also transferring, the stats is a little bit lower. And so transferring embryo, so like per transfer, and the percentage of embryos that are transferred and end up in implantation is 41%. And so less than half will actually take into pregnancy. And then half of those will end up in live births. So 45.7% will end up in a live birth. So that's half of half. And it's not very great. And that's for women under the age of 35. And as you get older, the stats just unfortunately go down. And so that's one of the reasons why we really, really advocate for women to work with integrative medicine too, to increase your chances of this actually being successful, because this is just a generalized all the cycles that happen in the US. It doesn't take in account if women were doing lifestyle changes or if they weren't. And so
It's
we
the
don't
whole
really know
pool.
the difference. Yeah, we don't know what the big difference is, but certainly there's enough research out there that shows that you can greatly increase your chances of a successful pregnancy when you take lifestyle into an account, and then also some natural therapies. And then just making sure reduced inflammation and everything that we've talked about on the podcast before.
I wish we
But when I
had all of those studies to exactly pinpoint, what things we can do. And actually, we just talked about this on an interview that's going to be coming out here in a couple of weeks about,
Mhm.
studying different interventions and looking at women that are kind of doing a whole handful of things to address diet and lifestyle. And, unfortunately, the studies aren't there to support that yet, to show what that looks like a whole healthy lifestyle protocol. We have studies that support, oh, yes, sleep is good. And oh, yes, exercise and stress management are good. And oh, a good diet is good. But we don't have the study yet that brings all of those things together. But you can imagine that if all of those things are awesome on their own, it must be pretty great to put them together because all those things kind of
Right.
work synergistically.
Kind of
So,
like a compounded effect.
yeah, good point there, Dr. Haley.
We would hope, yeah. And then I also wanted to just talk about what the percentages are as far as other diagnoses and like why a woman would need to use IVF, or a couple, right? So about 12% is due to tubal factors. So we talked about having the HSG and if your tubes are blocked for some reason. And then endometriosis is also 8% of that. So anatomical issues and things like that is around 8 to 12% of a reason. And then ovulatory dysfunction is about 16%. So like PCOS would often fall into ovulatory dysfunction, and diminished ovarian reserve. So that's what Kristen has been talking about when you just don't have, or you're kind of a poor responder, you're not making as many follicles on that day 3. And that's 31%. So 1/3. And then male factor is actually 32%. So that's really high. And I think a lot of women or couples don't know that, but there is a male factor involved 1/3 of the time.
Just by
So,
itself, right?
mhm.
Like only male, and then there's another percentage that is both, right? That's a combination of male and female factors?
Yeah, it said it says multiple factors, female factors only. So when there's multiple factors involved, it's 13%. So multiple factors would mean like you have diminished ovarian reserve and endometriosis. So that's 13% of the time. Female and male factors together is 17% of the time. And so, Kristen, you're right. So male factor alone is 32% of the time.
Yeah, so adding those together, that's a pretty hefty number. Like
Uh,
almost half of
yeah.
cases men are contributing to, which is consistent with what we've talked about before on the podcast.
What's really cool though is there's so many things that you can actually do for male factor, for sperm counts and things like that. Like a lot of environmental influences, and we have a whole podcast episode dedicated to that. So definitely something to think about.
And there's
If you're
great
having,
studies, yeah, to support all
Mhm.
that.
Yeah. Okay, so we've thrown a lot of stats at you. I'm going to just give you a couple more things that we came across when it comes to risk of doing IVF, especially with ICSI. Kristen mentioned that we are doing that about 66% of the time in the US now, which is crazy high. And it's just wild to both of us, I could speak for Kristen on this, is that they would actually just choose a sperm and inject it straight into the cytoplasm and boom, expect some amazing result. It's just strange to me that if, the sperm can't penetrate that egg on its own, why would you just then inject it into into the egg? But it's happening, and apparently there's some good benefit to doing that, to getting success rates. But there's some risk involved. So they have shown in research that female children that are born through a egg with ICSI are more prone to be obese in childhood, which creates a lot of risk growing up, cardiovascular risk, diabetes, PCOS, et cetera, et cetera. And then also, there's male factors too, where it increases the rate of chromosomal abnormalities or some congenital defects. So we've talked about male hypospatus, or when the ureter on the penis is in the wrong spot. And so that's a congenital defect. And then also there are a few other things. It increases the risk of development of autism, ADHD, and mental retardation. So that is going to be just a slightly higher risk. And in part of that reason is because when you go through IVF, you have a higher risk of having a small for gestational age baby or preterm birth, or also low birth weight. And so when that happens to the child, then research is showing that it's also connected to ADHD, autism, and some other of these neurological conditions. And so it doesn't come without risk, but we absolutely appreciate this technology to help women get pregnant when, of course, they had no other hope at all of it happening for them. But we wanted you to know all the facts, because I think it's not well known out there of people talking about the risks that come involved, that's involved in IVF. I think it's becoming very sensationalized right now, or desensitized to the actual involvement and of how much medications and impact it has on your body, and then also impact it has on the pregnancy and the outcome of your baby. So Kristen is going to talk to us a little bit more about other considerations when you're thinking about doing fertility treatments.
Yeah, well, I think it's a really good point that you made, that this is not necessarily, IVF is not necessarily an end all be all treatment. Like, we have tremendous respect for IVF. Like she mentioned, this is an incredible procedure that gives hope to couples and families who would otherwise not be able to conceive on their own. But it isn't successful 100% of the time. I think we need to be real about the success rates and be honest about that. And I think it's hard to always get unbiased information from a fertility clinic, because they're the ones selling you the procedure essentially. And so, there has to be kind of an unbiased information gathering. And that's kind of what we're trying to do. We are by no means anti-fertility treatment. We 100% believe in this method to be very successful for women and couples. And, what we really advocate for is that if you do need to go through this, that you take every possible measure that you can to make it successful, because it is incredibly expensive, and it can be stressful to go through stimulation, and it can be mentally and emotionally challenging for a couple to go through. And so doing everything that you can to increase your success rates, even though we don't have all the studies that we want to show the synergistic effect of different diet and lifestyle adjustments, we have enough studies to suggest that each of those things are great on their own. And then we have the expertise to kind of bring those together into an integrative fertility protocol. And, pretty much everything that we recommend would be a fertility clinic would be totally on board with, in terms of just increasing the health of the couple as much as we can during that phase that they're going through fertility treatment. So in terms of considerations, just like kind of a quick pro-con list for you guys to summarize some of these things. One of the major pros of IVF and other reproductive technology, mostly IVF, is that it's a fast timeline. Especially if you've been dealing with fertility issues for a while, or you and your partner are increasing in age a little bit. When we interviewed Krista last week, she's pushing into her late 30s by the time she figured out that she had tubal factor infertility, basically. And so it can provide a quick solution to a couple that's been struggling for a long time, or a couple that maybe doesn't have the time in their biological clocks, essentially, to do all of the diet and lifestyle stuff as a frontline treatment. And so, IVF can often be completed start to finish in the length of one menstrual cycle if you're doing a fresh embryo transfer. And a short stimulation protocol. So, that's great for couples who just kind of want to get it done and get through it. And there are also many different types and combinations of drugs and therapies available. So there are a lot of options on the table, and a good reproductive endocrinologist is really going to know when to use what protocol with what couple. So, these doctors are very good at what they do, particularly if you're going to a highly reputable clinic with great published success rates. You're going to find an RE that's experienced and is going to know exactly how to treat you and, increase your chance of success as much as you can through conventional medicine. So that's great. Some of the cons we've kind of already talked about are just statistically poor outcomes, in the 30s to 40% or so, per cycle. And that decreases sharply with age, into the teens and less for a couple or a woman in particular who's over the age of, is it 40 or 42? Maybe
Uh,
42. It goes
it's
down
for,
to
well,
like
I know it's,
7 or 8% or something for
oh
42
yeah,
and over.
it goes pretty low.
And then, of course, we talked about the high cost, and then the costs that are not financial, which would be physical from the injections and the hormones, and then the emotional cost, because not only is infertility stressful and hard on you emotionally, but the hormones can kind of add to that stress. And so we are going to talk about costs here in just a second. But I think the last thing that we just want to emphasize one more time is that IVF can result in a conception that would not have otherwise occurred naturally, particularly in cases when we're adding ICSI to the procedure and we're directly injecting that sperm into an egg when that sperm cell would not have been able to fertilize that egg on its own. So we're kind of creating a situation where we maybe just don't have quite the quality of materials that we would want to, and we're sort of forcing conception to happen. Now, that's not necessarily, we're not saying that all cases of IVF result in a less than optimal conception. It highly depends on what the conditions are that the couple is dealing with, but that is one risk. And, some of the studies that are being done on health outcomes in children that are born through IVF do kind of highlight some of that risk a little bit. But once again, we are not by any means anti-fertility treatment. We just really want to give you an unbiased look at the stats, the risks, and the costs. So let's get down to cost for IVF. Everybody knows that this procedure is expensive. Actually, we'll start by talking about the cost of medicated cycles without any procedure like IUI, or IVF. And a medicated cycle is pretty inexpensive. One cycle of Clomid or Femara is going to be, about $100, no more than a few $100s, depending on whether or not you have insurance coverage for it. And, just the cost of the drugs is basically all you're doing. Now, IUI costs can vary a lot because you can do a simple procedure with just Clomid or Femara and an IUI procedure, no sperm donation, nothing like that. And that could be, a few $100s, $400 or $500. But if you are using gonadotropins, injectable hormones for your IUI cycle, you could be up as much as $4,000 for an IUI. So it really depends on your specific situation and the drugs that are recommended to you to use in that protocol for IUI. And then once we get to IVF, the costs skyrocket from the other types of treatment. So an average cost for IVF is about $12,000 per cycle. And that is just really for the procedure. Some of that might include some of the pre-cycle monitoring, but depending on how much testing you need, it may not include all of the testing that you need to have done before you can start your cycle. And that number does not include medications. So that's just basically the cost of the clinic doing the monitoring and the procedure, the actual IVF procedure. That doesn't include all of those injectable medications that you need to do your stims. And so medication can add, depending on your protocol, because like we mentioned, there are different drugs, different lengths of protocol, different doses. You can be up as high as $5,000 for medication. And I've actually heard of some protocols being even more expensive for medication, depending on where you live, what you're using, and what your clinic is charging. So, and then there are some optional services that can be added on top of just the IVF procedure. So, if you have to do sperm donation, if you can't use your partner's sperm for the IVF, that can add as much as $3,000 to the cost. If you want to do genetic testing or look screening for chromosomal abnormalities, that can add up to $3,000 to the cost. And then ICSI as well is going to add to the cost. So, like I said, depending on the clinic, these services range between 1,500 and 3,000 addition, and that's on top of medications and on top of that kind of base $12,000 average that we already mentioned. So lots of things can add to the cost of IVF, being already expensive in itself. And then IVF with egg donation. So if you and your partner are not able to use your eggs, is about $28,000 on average, but can be even more than that, especially if you also need to do like sperm donation, for instance. So unfortunately, in the US, there's really not a lot of insurance coverage for fertility treatment. There are actually only 15 states in the US that have laws that require some level of insurance coverage. Now, your company might contract with an insurance company or have a plan for you that offers some coverage for your fertility treatments, but it's certainly not required, and it's going to be really variable from person to person, from company to company. And then, depending on where you live, if you're outside the US, there are some places like in Europe, and I think maybe also in Canada, where there's some government sponsorship, or there are certain programs that can pay for partial cost of IVF, and some that can even get you an entire cycle covered. But if you have to go through multiple, you're going to be paying a fair amount out of pocket, regardless, if you have to go through more than one cycle. So, lots of things to consider there. And, we just want you to know what your options are and to kind of understand all the moving pieces. Now, we are not conventional fertility experts. And so we do want to let you know that, all the information that we've shared today is what we have to the best of our knowledge. But if you have specific questions about a protocol or any concerns about anything that we've discussed today, please talk to your reproductive endocrinologist, discuss things with your fertility clinic. I think one of the biggest pieces of advice I have is just to make sure that you're working with a doctor and a clinic that is willing to answer all of your questions, that has no qualms talking to you about the success rates of the clinic, that's very open and transparent about those numbers and what they can offer you, and is very upfront with you about your own lab results. Because like we mentioned, there are some tests that can indicate whether or not you'll respond well to IVF. And I think some couples may be recommended IVF that won't necessarily be great responders to that treatment. And sometimes, there are very real situations in which your chance of, barring tubal factor or some serious anatomical issue, there are situations where your chances of trying naturally really aren't any worse than doing IVF. And in that case, do you really want to go through and spend the money? So, making sure that we're not viewing IVF as the fix all to every fertility issue. And that's something, we have another interview coming up pretty soon that is going to talk a little bit about that, about being real with patients. We actually talked to a conventional reproductive endocrinologist. She was kind enough to give us some of her time and talk through her process with patients and how she discusses IVF treatment with them, and just getting real about it. It was very interesting to talk to her and have her say something along the lines of, as an RE who does IVF procedures, I spend a lot of time advising couples against IVF. And so if you have somebody that's willing to have that candid conversation with you, that's the type of provider that you want. That's the type of clinic that you want to see. And so that would be kind of our recommendation for how to proceed forward with fertility treatment if you do need to go that route.
Yeah. Very well said, Kristen. Thank you so much. That will be our interview next week, actually, with Dr. Laura Shaheen. And she is an RE up in Seattle. She's pretty dang amazing. The interview was really great. So we hope that you'll tune in next week as well to hear her take on fertility clinic treatments. And then she actually wrote a book on recurrent miscarriage, and it's called Not Broken, and it's a really well-written book. And I loved it. And we talk about her book in that podcast interview as well.
So we'll be very much looking forward to sharing that with you next week. So I think that's going to wrap things up for today. We do want to remind you about our free fertility recovery guide, which you can access through the link in the episode description. And that is basically a PDF guide that takes you through 5 steps that you can start taking today to improve your diet, your lifestyle, your exposure to toxins that are known to disrupt hormones and cause problems with egg quality. And so these are things that we highly recommend that you get started on to improve your odds of success if you need to go through conventional fertility treatment. And then even if you're trying naturally, these are the same types of things that we would be recommending to women that have maybe been trying to conceive for a little while and haven't been able to. And then if you're just in the preconception period and you want to be as healthy as possible, it can help you as well with that. So go download that guide. And then lastly, we just want to invite you to follow along with us on social media. We are on Instagram daily, and we do Facebook Lives on our page every Wednesday. We usually go over just some highlights from the week's new podcast episode and answer questions and point you toward helpful resources that we have just to give you more information. So we'd love to see you over there. And we're on YouTube as well. So
yeah, you can find us at tinyfeet.co. And so that's tinyfeet.co. And that's our handle for Facebook, Instagram, but not YouTube. YouTube is Mastering Your Fertility TV.
Yep. All right. Well, we will see you guys back next week. Thanks so much for joining us.